Okay.
Welcome to everyone. I'm very happy to launch this third Wednesday series. And I just want to make a small introduction on what is the woman in lymphoma, who we are, what are our aim, and what is the kind of dissemination that we want to get series after series. So not many women are represented in leadership position in academic medicine. The WiL initiative has emerged at the International Conference on Malignant Lymphoma in Lugano 4 years ago, when women decided to organize to help each other internationally for lymphoma career. Women in Lymphoma is now a collaborative alliance of more than 320 lymphoma doctors, researchers, and educators from around the world. The steering committee is led by Judith Trotman from Australia, Anne Lascas from Boston, sorry, and Carla Casullo from New York. We have integrated new members in the steering committee, emerging in their career. So we are very happy to welcome for this Wednesday, WiLing Wednesday, Paola Gion from Buffalo, USA, Justine Kahn, New York, USA, Caroline Mawat from Buenos Aires, Argentina, and Clémentine Sarkozy from Paris in France. So welcome to you. A key focus of women in lymphoma is to mentor other women, encouraging them to put themselves forward for career progression opportunities. One of the major achievements of the women in lymphoma is the WiLing Wednesday, a high-level education program every week for 5 consecutive weeks, every 3 other months. The first WiLing Wednesday series was in September, dedicated to diffuse large B-cell lymphoma. In January, the focus was on Hodgkin lymphoma, and we launched today the third series on T-cell lymphoma. So do not forget to register. So I try to to go to the other. To the second slide, what is not, I don't know, what, this one. So do not forget to register for the coming weeks. So you go to the Women in Lymphoma site and you register, and then you will receive a calendar book. Thank you, Laurence and Kerry, for accepting the invitation. Thanks to MSD and Roche for their support. And thank you, Anna, for the organization. The session will be recorded. You can watch it later when visiting the website Women in Lymphoma. So now it's time to welcome. Sorry. Why does it work? Sorry. So I don't know how to make the slide. So this is the series of the T-cell lymphoma, women in lymphoma, WiLing Wednesday. So now it's time to welcome Laurence de Leval and Kerry Savage for an update on pathology and primary therapy for peripheral T-cell lymphoma. Professor de Leval is full professor of pathology and director of the Institute of Pathology at the University Hospital of Lausanne, Switzerland. Laurence de Leval is an internationally recognized expert in hematopathology. She received the Benjamin Castelman Award presented by the United States and Canadian Academy of Pathology in 2008 for her discovery of the follicular helper T-cell derivation of angioimmunoblastic T-cell lymphoma. Her current research is focused on exploring the molecular pathogenesis of NKT cell malignancy. Laurence de Leval has authored more than 250 scientific publications and several chapters for reference textbooks in pathology and in hematology. She is elected member of the International Lymphoma Study Group and corresponding member of the Belgian Royal Academy of Medicine. She is a member of several national and international scientific societies, co-chair of the T-cell lymphoma working group of the LISA. So welcome, Laurence. Thank you very much. And the floor is yours.
Thank you very much, Florence, for the introduction. While I'm uploading the slides, do you see my screen like this? Do you see my screen?
Yes, it looks perfect.
Yes, thank you, Laurence. Thank you. So I would like to thank you, Florence, thank the organizers and the steering committee of the Women in Lymphoma group for this invitation. My pleasure and honor to provide today an update on T-cell lymphoma pathology review. So basically, peripheral T-cell lymphomas can be viewed as neoplasms of immune cells, and immunologically we have two arms to the immune system, the innate and adaptive, and neoplasms derived thereof have different properties. Those derived from the innate immune system are mostly account for extranodal entities. Likewise, the normal counterpart, they are located in the skin, mucosa, the spleen, the bone marrow. They have cytotoxic properties, frequent apoptosis and necrosis. The adaptive immune system, which comprises the conventional alpha-beta T cells, CD4 or CD8, with multiple functional subgroups, is the source of most nodal peripheral T-cell lymphoma entities, which are related to subset of effector T cells. That's for the biology. Now, considering T-cell lymphomagenesis, we have to keep in mind the role of viruses, HTLV1, ABV in some entities, the role of predisposing conditions like celiac disease or others, and importantly, genetic basis, mostly acquired genetic alterations as the main oncogenic mechanisms. And in that respect, with the major advances in the knowledge in the molecular pathology and genetics of these disorders over the past years, mostly following technical advances and especially next generation sequencing over the past years have led to the discovery of many fusions or mutations that are instrumental in T-cell lymphomagenesis. We have also seen in that respect that the classification and the definition of T-cell lymphoma entities has evolved and has become more complex. While there were certain entities described in 2001, the lastly revised WHO classification comprises almost 30 T-cell lymphoma entities. And these can be grouped according to the clinical presentation of these disorders as leukemic, predominantly nodal, predominantly extranodal, and cutaneous. Interestingly, the cutaneous T-cell lymphomas are quite relatively common, and they outnumber the T-cell, the B-cell cutaneous lymphomas, which is not the case for the systemic disease because T-cell lymphoma account for less than 10% of all non-cutaneous lymphomas. The topic today will be to focus on the most common entities, and these correspond to those presenting as predominantly nodal diseases. On this scheme, which represent the distribution of the systemic T-cell lymphoma entities in the world or in the French registry, as you see, those nodal entities account for more than 2/3 of the cases, with a high proportion of angioimmunoblastic T-cell lymphoma and related entities, followed by peripheral T-cell lymphoma not otherwise specified, and anaplastic large cell lymphomas. These three groups of diseases can be schematically represented like this as three biologically distinct groups, but also with some overlap between these entities, and especially around the peripheral T-cell lymphoma, not otherwise specified subgroup, which is a diagnosis of exclusion. I will start with discussing the large group of nodal lymphomas of follicular helper T-cell origin. This is how angioimmunoblastic T-cell lymphoma and related ends in the WHO classification. So the follicular helper T-cell, also called germinal center T-cell, represent a specific subgroup of CD4 positive helper T-cells that in physiological conditions are located in the apical zone of the germinal center. That's what you see on the right-hand side as identified by immunohistochemistry. These TFH cells are equipped with a particular array of secreted molecules and cell surface receptors in order to interact with B cells and provide the help for antibody production. Among the markers that are rather specific for the TFH subsets include transcription factors like BCL6. Among the soluble factors are interleukin-21 and CXCL13, and among the cell surface receptors are CXCR5, which is the receptor to CXCL13, ICOS, PD1, and CD40 ligand, which can interact with the corresponding counter receptors on the B cells. So angioimmunoblastic T-cell lymphoma is the prototypic lymphoma, which is derived of mature TFH cells, and it is described as being characterized by systemic disease, a polymorphic infiltrate that involves the lymph node with a prominent proliferation of venules and also follicular dendritic cells, and a frequent expansion of EBV positive B cells. Talking about systemic disease, one refers to the fact that the disease is often disseminated, accompanied by B symptoms involving lymph node, but also commonly the spleen and the liver, with frequent extranodal presentations and effusions. It's accompanied by an array of biological disorders, including anemia, which is often CUMS positive, other cytopenias, hypereosinophilia, and hypergammaglobulinemia. On the scheme on the right, what is shown there is to illustrate that the TFH nature of the neoplastic cells in AITL likely explain these symptoms and the architecture of the tumor, which comprises a lot of microenvironment, which is recruited by the factors secreted or the molecules expressed at the surface of the TFH cells. So in a way, these biological disorders may appear as a form of that TFH-derived neoplasm. This is a typical example how it looks histologically. AITL is characterized by the lymph node architecture. At higher power, lower left, you can see that the infiltrate is typically polymorphic, comprising not only atypical lymphoid cells, but also larger blastic cells, typically polymorphonuclear eosinophils. The panoramics on the right show the the typical immunoarchitecture of this disease, which comprises an abundant net meshwork of follicular dendritic cells shown by CD21 positivity. The T cells are an important component. They're the neoplastic cells. They're positive for CD3 and CD4 cells, may morphologically positive for CD. The cells initially discovered by gene expression profiling studies has translated into the fact that TFH markers can be used by immunohistochemistry or by flow cytometry phenotype, which is one of the characteristics of this disease. And among the markers of TFH cells are included CXCL13 and CD10, which are quite specific, but not so much sensitive. Less specific are ICOS, PD1, CMAF, and BCL6, probably somewhere in the middle. So typically in AITL, the neoplastic cells express, sometimes it's only a small proportion of the tumor cells, which are the neoplastic ones, and express these markers. The application of these markers to various histological conditions has T-cell lymphoma. So besides the diffuse proliferation involving and effacing the lymph node, the position where the tumor cells are terminal centers, that's so-called the perifollicular pattern of which can be confused reactive. It has also led to the recognition that a large proportion of lymphoma that were called Lennert lymphoma, because of the presence of an abundant histiocytic component, as seen on the right, were indeed TFH derived lymphoma qualifying for angioimmunoblastic. And beyond AITL itself, it has also been recognized that a subset of cases that would have been classified in the past as not otherwise specified because they do not have the morphological characteristics suggestive of AITL also belong to the same spectrum with a TFH phenotype. And these include follicular T-cell lymphoma and peripheral T-cell lymphoma with TFH phenotype. The first one is very rare, and the second accounts for a significant proportion of cases not otherwise specified by morphology. Follicular T-cell lymphoma by morphology looks like it forms follicles. It can mimic follicular B-cell lymphoma or can mimic also some forms of nodular Hodgkin lymphoma, but the immunostains reveal that the cells forming the nodules, which comprise follicular dendritic cells, are T cells expressing TFH markers. There's some overlap, but not complete in terms of the clinical features with angioimmunoblastic T-cell lymphoma. Nodal peripheral T-cell lymphoma with a TFH phenotype is a more common occurrence. An example is shown here. By morphology, you see a rather monomorphic proliferation of large cells. It is mostly T cells, CD4 positive, and as you see, they express strongly PD1 ICOS and also significantly CXCL13. So they express at least 2, that's the definition. It's better if you see 3 TFH markers. And at these cases, if you would perform gene expression profiling, you would see that they contain some traces of the overexpressed genes typical of the angioimmunoblastic T-cell lymphoma. By gene expression profiling, again, these follicular or TFH type of PTCL, as you see, they tend to cluster with the angioimmunoblastic T-cell lymphoma and stay more away of the other T-cell lymphoma not otherwise specified. They express a strong TFH signature, but they differ from the AITL by a lesser expression of the microenvironment signature, which is a predominant feature of AITL and is less present in those 2 related entities. Beyond sharing a common TFH phenotype, several studies have established that these TFH lymphomas also have in common a unique mutational landscape. And this consists typically in the association of multiple mutations involving epigenetic regulators and signaling molecules along the TCR or the JAK-STAT pathway, and also other alterations that are lesser specific. The epigenetic regulators that are more commonly altered include TET2 altered in the majority of the cases, DNMT3, and also IDH2, which is relatively specific for AITL and not found in the other TFH lymphomas. Remarkably, those cases with the IDH2 mutation, they tend to have some distinct morphological features. That is the presence of prominent clear cells in the tumor, and they also tend to express a very strong TFH phenotype. Among the signaling molecules, there are multiple alterations described, the most prevalent being the RhoA mutation in 50 to 70% of the cases, but also various alterations along the TCR signaling pathway. And this is now the main alterations are shown here. There are different fusion genes and mutations. Among the fusion genes, the first one to be described was the very rare and was found in association with follicular T-cell lymphomas. More common are CD28 fusions to ICOS or CTLA4, and more recently described, but apparently more frequent, are fusions involving the FIN molecule with TREF3IP2. This fusion, which activates ultimately NF-kappa B, is found in a relatively large proportion of TFH lymphomas, but also in T-cell lymphoma not otherwise specified. Among the mutations, the point mutations, the RhoA G17V mutation is very frequent. It is distal in the TCR signaling and acts as the dominant negative. Other mutations involve more proximal molecules like CD28, LCK, FIN, PLC gamma, VAV1, or CARD11, and overall, they tend to have an activating role on the TCR pathway. The presence of these multiple mutations in the tumors, as shown here, presents with some form of hierarchical distribution. And as you see, TET2 mutations are the most frequent. RhoA mutations tend to occur in cases having TET2 mutations, as is the case for IDH2 and many of the signaling pathway mutations. These observations, but also findings derived from sequencing of sorted cell populations and bone marrow fractions from diseased patients, as well as animal models, have led to this model, which is depicted simplified on the bottom cartoon, showing that TET2 and DNMT3 appear to occur in early hematopoietic progenitors. In other words, AITL tends to occur in the background of clonal hematopoiesis. These mutations, which are transmitted to the progeny, are being added with secondary mutations involving the signaling pathway, or also IDH2 is considered in that category, and lead, when occurring on the T-cell pathway, lead to T-cell lymphoma and a TFH skewing of the differentiation. This model, as early mutations are being transmitted to both myeloid and lymphoid progenitors, probably explains the coexistence with myeloid neoplasms reported in a few instances. Also, the fact that B cells may harbor some of the mutations may explain that B cell expansions with additional mutations, positive or negative for EBV, may supervene on these T-cell lymphomas. This was for this first large group of neoplasm. On the opposite side, let's say, of the PTCL NOS is the group of anaplastic large cell lymphomas. And ALCLs have in common that they're composed of large cells that strongly and uniformly express CD30. And this is how they are classified. So as I said, on the left, you see what is the morphology of what is called anaplastic cells. These are very large. Sometimes they are donut shaped. They tend to be cohesive. They include what is called the hallmark cells. Hallmark cells have a horseshoe-shaped nucleus, and they have a clear Golgi zone around, and seen here the typical strong CD30 expression. Among these is a very well-defined group of ALK-positive ALCL and 3 entities of ALK-negative ALCL, systemic, cutaneous, and breast implant associated. ALK-positive ALCL it's defined in the WHO as a T-cell lymphoma with large cells, abundant cytoplasm, pleomorphic horseshoe-shaped cells, expression of CD30, and translocation of the ALK gene and expression of the ALK protein. So the first discovered ALK translocation was the T25 NPM1 ALK gene fusion. That's the most common, but there's a variety of other translocations involving the ALK gene onto Q25. The type of a translocation in a way dictates the distribution of the expression of the fusion protein. It's nuclear and cytoplasmic in NPM ALK translocation, but it can be mostly cytoplasmic, sometimes granular or membrane in the case of other translocation. It seems that the type of the translocation does not really have impact on clinical feature. Essentially, also no correlation with what we will see are the morphological variants of ALK-positive ALCL. ALK-positive ALCL, besides the basic defining criteria, is also a cytotoxic lymphoma. It's often positive, aberrantly positive for an epithelial membrane antigen, and it's characterized by a loss, which is sometimes massive, of T-cell antigen expression. That's what is referred to as the so-called null phenotype that is sometimes used to qualify ALCL, which do not or barely express T-cell antigens. The disease occurs mostly in children, nodal or extranodal, and has a good prognosis. Regarding the morphological variant, the most important are those called small cell variant, illustrated on the upper panels. You see mainly small cells with abundant cytoplasms. Only occasional cells are larger. And when applying CD30 and ALK immunostains, which are instrumental to identify this disease, you see that only a subset of the cells which stain positively, mostly in a perivascular distribution. A lymphohistiocytic variant shown left lower corner comprises scattered large cells with a predominantly histiocytic background, and this entity can be confused with reactive conditions. Not only they may cause problems for diagnosis, these variants, but also they are clinically relevant, because as seen in this study published 10 years ago in pediatric ALCL, you see that those with a variant morphology tend to have less good outcome. Turning now to ALK negative ALCL, by definition, it should be morphologically indistinguishable from ALK positive ALCL. It tends to occur in older patients with a worse prognosis. What is required is the triad of the features of ALCL: hallmark cells, cohesiveness, and strong homogeneous CD30 expression. What is desirable is a reduced T-cell antigen expression, cytotoxicity, expression of EMA, and some sinusoidal growth in the lymph nodes. While this entity has been described and defined in a way by default and by opposing to ALK positive, in the recent years, it has been shown that this entity is also underlined by recurrent genomic aberrations. It's an inhomogeneous entity, but among the most recurrent alterations are the rearrangements of the DUSP22 locus in about 30% of the cases. These rearrangements with various partners downregulate DUSP22, which is a phosphatase that normally inhibits T-cell receptor signaling. This rearrangement can be detected by FISH. It is illustrated in a case on the right. These DUSP22 rearranged cases, they often have a typical morphology with a lot of hallmark cells, as indicated by the arrow. They tend to be completely negative for the cytotoxic markers and also tend to not express EMA. TP63 rearrangements are less common, and these cases tend to be positive for P63, but this is not specific to those harboring the TP63 rearrangement. Other subsets harbor rearrangements of VAV1, ROS1, or TYK tyrosine kinase. In addition, point mutations may occur along the JAK-STAT pathway, mostly in STAT3 and JAK1. The DUSP22 rearrangement co-occurs in 1/3 of the cases with a point mutation in the musculin gene, and there are also some epigenetic alterations. Clinical studies in correlation with the genotype have found some correlation with respect to the prognostic significance of DUSP22 rearrangement and TP63 rearrangement. In two studies, DUSP22 positive cases were found to be of better prognosis than those not harboring that rearrangement. But this was not confirmed in another study. Probably Kerry can talk about this, from British Columbia, where the DUSP22 rearranged cases had some of those high-risk clinical features and also lesser prognosis. TP63 is rare, but tends to be associated with a very bad outcome, while those not harboring so-called triple negative for ALK-DUSP22 and TP63 have an intermediate prognosis. Breast implant-associated ALCL is the last kid on the block in that category that was introduced as a provisional entity to qualify ALK-negative T-cell lymphomas arising in association with a breast implant. That tends to occur at a median of 10 to 13 years post-implantation in women having had this for cosmetic or reconstructive mammoplasty. Both saline or silicone implants may be incriminated, but what seems to be important is the macro texture quality of the capsule. There's an increased risk in the relative increase is high, but the absolute risk remains very small, according to a Dutch study of estimated to about 1 to 12,000 women harboring a breast implant at the age of 70 years. Importantly, there are two clinical presentations, one illustrated by the smear shown on the upper part of the cartoon. It occurs as an effusion around the implant, a seroma type of lymphoma with cells suspended, large cells suspended in the fluid, or as an infiltrated tumor mass, as shown lower left, infiltrating into the adjacent parenchyma. And these two clinical presentations have different outcomes, the outcome being better for the seroma type. Axillary lymph node involvement may occur, and that's also an adverse prognosis. BI ALCL has many features in common with the other ALK-negative ALCL, the basic pathological features, many of the mutations, including in the JAK-STAT pathway, epigenetic modifiers, and cell cycle deregulation. They differ in that they are triple negative, DUSP22, TP63, and ALK rearrangements have not been found, and they're usually localized and indolent with a characteristic hypoxic expression signature and some peculiar 20q imbalance, which appears quite typical for that entity. It is thought to occur as a result of a local chronic inflammation evolving towards the acquisition of mutations, possibly immune escape mechanisms with PD-L1 overexpression, and the evolution to a clonal disease in a peculiar and confined microenvironment. This slide is for us to remember that CD30 protein expression is mandatory for diagnosis of ALCL, but it is not specific, and CD30 expression, even strong, can be observed in a subset of many other T-cell lymphoma entities, including PTCL NOS, but also extranodal entities. On the right, for example, is illustrated a case that was an extranodal NKT cell lymphoma, EBV positive, which presented as a large cell tumors with a strong CD30 expression. And finally is the group of T-cell lymphoma called not otherwise specified, because it is an exclusion diagnosis within this kind of a waste basket entity. It is recognized that there are some subgroups defined by molecular features, defined by the association to EBV for certain cases, defined by cytotoxicity for another small subset, despite the fact these subgroups have not really yet made it into official subgroups or into being mandatory for subclassification. PTCL NOS encompasses diagnostic challenges because not only one has to exclude the other common nodal T-cell lymphoma entities, but also exclude the possibility of a nodal presentation of an extranodal type or a cutaneous lymphoma. One has to make sure we're not dealing with an HTLV1 positive ATLL, and there are many benign mimics as for AITL also, which can make the diagnosis difficult. So importantly, as an exclusion diagnosis, one has to make sure that the cases are being tested for TFH markers before retaining a diagnosis of PTCL NOS. These are usually aggressive tumors of adults. Variable cytomorphology can range from small and monomorphic to large and polymorphic. Sometimes there's prominent eosinophilia or prominent microenvironment. Most cases are derived from TCR alpha beta, rare cases are gamma delta, and CD4 positive cases outnumber CD8 positive. From gene expression profiling studies and meta-analysis of this, it was found that two subgroups of PTCL NOS could be delineated that had some commonality with the expression patterns of TH1 and TH2 normal T-cell subsets. So these two molecular subgroups referred to as TBX21 for the TH1 subgroup and GATA3 for the TH2 subgroup were initially described by gene expression profiling. It has been developed an algorithm that in a way it's a little bit analogous to the Hans algorithm we use for DLBCL. This algorithm uses major transcription factor but also chemokine receptors to define and delineate the two TBX1 and GATA3 subgroup. The interest is the notion of a biological subclassification of these neoplasms, but also there's a suggestion that the GATA3 subgroup might be of a worse prognosis than the TBX21. In addition to this, it seems that on the genetic level, these two subgroups are also distinct, with the GATA3 having more copy number changes, tends to have alterations in the cell cycle regulation, including CDKN2A, TP53, also alterations in the PTEN and PI3 kinase pathway. Gains and losses are distinct in the TBX21 subgroup with an activation of the APMK and mTOR pathway. This is now my last slide to conclude that in the nodal PTCL we have three main groups of disease with a large spectrum of pathological features. I did not have the time, but this is a difficult diagnosis for pathologists with a differential in several instances with reactive conditions with other lymphomas. It can be compounded by the occurrence of superimposed EBV positive B-cell processes. So in principle, it is important to have a good diagnosis to avoid the needle core biopsies and at least for first diagnosis to have a good biopsy. With this increasing knowledge about the genetics, there's also in parallel an increasing importance of genetic testing and profiling in the diagnostic practice. Panels of genes have been a proper setting. The other interest and importance of the evolving classification and knowledge is that these mutational landscapes have led to the identification of potential biome of responses to therapies. And with that, I would like to thank you for your attention. These are pictures from Lausanne, and on the right is my hospital. In the background, you see the lake to the right, and the arrow points at my institute. I'm currently in Belgium now, but this is where I usually work. I leave the floor to Kerry and look forward to hear about the treatments.
Thank you so much. I appreciate that. Unfortunately, I think we're gonna have to move on just because of the time. I'm sure we can try to get any questions to you that people may put up. So it's my pleasure to introduce Dr. Kerry Savage. And Dr. Savage, of course, is a well-known lymphoma oncologist from BC Cancer Agency. And she's a professor of medicine at University of British Columbia. She did her MD at University of British Columbia and postdoctoral fellowship at Dana-Farber, and also a master's in epidemiology from Harvard. And we all are very familiar with her wonderful work in all the different areas, peripheral T-cell lymphoma, the subject of today. So she's going to talk about the clinical aspects of some of the entities of peripheral T-cell lymphoma. Thanks, Kerry.
Thank you, Julie. I'm just going to switch over to sharing my screen. And okay. So thank you so much for the kind introduction and the invitation to participate in this WiL session. I'm just showing a brief slide here of Vancouver in springtime. When you're able to fly again, I highly recommend it. It's one of our best times of year. It's also a pleasure to be paired again with Laurence. We've done talks in the past. Here are my disclosures. You've already had an introduction. I just have a few slides on pathology, but I remind you that PTCLs are complicated. We're focusing on the nodal subtypes today, and you'll hear about the extranodal subtypes, I think, next week. So we've had a lot of challenges in understanding and improving outcomes in peripheral T-cell lymphomas. In addition to disease rarity and heterogeneity, most of the subtypes and most of the studies in the past have included all subtypes, and that does obscure potential for subtype-specific drug sensitivities. And treatment paradigms have been largely borrowed from diffuse large B-cell lymphoma. We have few randomized controlled studies, and historically CHOP has been considered the standard backbone, but it's very clear that one-size-fits-all approach doesn't work in PTCLs. So as you're aware, the outcomes for most PTCL subtypes is poor, with the exception of ALK-positive ALCL, and I've just shown here two of the largest retrospective studies, one from the International T-cell Lymphoma Project that Julie Vos led and we participated in. NOS and angioimmunoblastic T-cell lymphoma in a population-based setting have very poor outcome at the 5-year PFS of 20%. ALK negative has a little bit better outcome, but you'll also see, if you compare studies, quite a discrepancy, and we're starting to understand why, as ALK negative ALCL is more complicated than we thought it was previously. So just a snapshot of what we know. It was over 20 years ago that ALK positive ALCL was defined based on the translocation, and now, of course, the ALK1 antibody is used in routine practice. But it's in the last 7 years or so that ALK negative ALCL has been divided into these 3 genetic subgroups. DUS22 rearrange, as you've heard, generally has a good prognosis, but in my mind, similar to ALK positive ALCL, not everybody does well. So I think we need to really have large series to fully understand the disease spectrum. So the angioimmunoblastic T-cell lymphoma and TFH PTCLs, as you've heard, they're in the last update of the WHO, we now have this unified category, and recurrent mutations have been identified in angioimmunoblastic T-cell lymphoma. We don't have large-scale studies in TFH PTCL, but from what we're seeing, looks like the mutational profile is similar. And I'll come back to this point in a minute. We do have cumulative evidence that this group of diseases has specific drug sensitivities to HDAC inhibitors, hypomethylating agents, and AZH2 inhibitors. Now moving to the so-called wastebasket diagnosis, PTCL NOS. This was a category that we've been waiting to subclassify, as pathologists do their best to slot patients into one of the specified categories, and this is really a default category. As you've heard, I think the closest we've come to this is from Javid Iqbal in the LMPP, where two dominant clusters were identified in gene expression profiling. One termed GATA3 and one TBX21, where GATA3 cases seem to have a more aggressive course. Importantly, in this study, 20% of cases were unclassified, so we're still not done with NOS in my mind. But looking at the gene signatures, and although this is a bit of hand waving, there is some clues that perhaps these different subtypes might respond to different drugs. So how do we move beyond CHOP and peripheral T-cell lymphomas? Well, it's, as you know, it's no longer the standard in some of the uncommon extranodal subtypes like extranodal NK T-cell lymphoma and hepatosplenic T-cell lymphoma. CHEP-BV is now the standard in CD30 positive peripheral T-cell lymphomas. I'll talk about that in a bit more detail. But beyond CD30 positive peripheral T-cell lymphomas, an ongoing debate is CHOP the right backbone, or should we abandon CHOP altogether and move to novel agent combinations, even in the frontline setting? So what are some past strategies that have been used to improve upon CHOP? Probably the most popular is consolidative transplant. CHOP is often used instead of CHOP. I'm going to talk about these two in a little bit more detail in upcoming slides. And then probably about 10 or 15 years ago, there was a movement to abandon CHOP and build a new chemotherapy backbone. And with gemcitabine having good single agent activity, that was investigated. But unfortunately, that was a bit of a bust and those studies were negative. It might speak to the importance of alkylators or possibly the importance of anthracyclines, although there's been mixed data in prior studies on that. Where did the first data come for interest in CHOP in a frontline setting of peripheral T-cell lymphoma? So this is a study from the German non-Hodgkin study group, where they pulled out patients with a T-cell phenotype that had been enrolled on prospective studies. And they asked a number of research questions, one of which was, if you add etoposide to the frontline regimen, did it improve outcome? And in this case, it was event-free survival. And the answer was yes. And they looked both at CHOP and from the BH1, and they also did another analysis where they combined it with high CHOP. But if you pull out patients with L-positive ALCL, it interestingly seemed to derive the most benefit from CHOP. But we do see a trend in the same direction in the other nodal subtypes. It just doesn't quite reach statistical significance. There's some caveats to this analysis. The study was restricted to younger patients with a normal LDH. It was unadjusted, and there isn't an overall survival difference. But there have been subsequent retrospective studies that have similar theme of younger patients that may benefit, but it's certainly not level A evidence. What about consolidative transplant? You're going to hear about this in future talks, so I just want to highlight a couple of points. Like the common problem in PTCL, we don't have randomized controlled studies showing superiority. I could spend a talk showing you retrospective evidence for and against stem cell transplant, and we have very few prospective studies, and of course they include diverse subtypes given disease rarity. Having said that, given that the relapse rate is high with CHOP-like regimens alone, it is considered in most subtypes and in most guidelines, with the exception of L-positive ALCL. And I think the best data we have is from the Nordic phase 2 study. It's 160 patients with most frequent subtype PTCL NOS. And in the intention to treat population, the 5-year PFS was 44%. If you pull out the outcome by subtype, although this is not statistically significant, there's a hint that maybe ALK negative and angioimmunoblastic T-cell lymphoma might benefit more from transplant. In a subsequent study on the ALK negative cases, almost a quarter of them do have a DUS22 rearrangement. So this is going to be a more selected population. So my bottom line is the outcomes with transplant from this study are better than what you would expect historically. Obviously, it's not a home run, and this is also a highly selected population, and we obviously need better upfront therapy. So I'm going to take you through a rocky road for replacing CHOP and peripheral T-cell lymphomas, and the most popular approach has been adding a novel agent. And there have been a number of phase 2 studies and some phase 3 studies over the years that have not shifted that therapeutic bar. There's a few that are work in progress, but the one that has moved the therapeutic bar is the CHEP-BV in the Echelon-2 study that I'll talk about. But what hasn't worked? So here are two of the negative CHOP plus novel agent phase 3 studies. One was from the German non-Hodgkin study group, so ACT-2. ACT-1, which was in younger patients, was also negative. And then we recently heard about the Roe CHOP study at ASH last year, which was also negative. In addition, it's a bit sobering to see the baseline outcome with a 3-year PFS with CHOP of 35%. These are both older populations as well. Some other lessons learned from these studies: it's not easy to combine drugs with CHOP, and we have ongoing challenges with disease heterogeneity and trying to pick out, is there a patient population that actually benefits from these novel approaches. So what we need to do is obviously pick the right novel agent and the right disease, and we've seen success with CHEP-BV and CD30 positive PTCLs. So as a reminder, brentuximab vedotin is an antibody drug conjugate targeting CD30. The active moiety is MMAE, or monomethyl auristatin E. There were parallel phase 2 registration studies developed in both relapsed refractory ALCL and Hodgkin's lymphoma. And I've shown here the waterfall plot from the original registration study. You can see almost all patients respond. The objective overall response rate was almost 90%. Over half have a complete remission. And the curve is from the updated mature follow-up that was published a few years later. There's a nice plateau there, and although a lot of these patients went on to transplant, there's about 10% of patients that receive BV alone, suggesting that in some patients it may be curative even without transplant. But this data led to exploration in the frontline setting in Echelon-2, which compared CHOP to CHEP-BV, and this was a double-blind, double-dummy. As a reminder, the CD30 positive designation was by the local laboratory, and it had to be 10% or more. The study targeted to have 3/4 of the patients with anaplastic large cell lymphoma, and that was due to a regulatory requirement in Europe and Canada, as this was meant to be a confirmatory study for the original single agent indication. The primary endpoint was PFS, so it's different than Echelon-1, which was modified PFS. And events did not include consolidated radiotherapy and stem cell transplant. As per the study design, most of the patients had ALCL. So at the end of the day, 70% of the patients had ALCL that went into the study. And just to highlight, if you look at the two most next commonest subtypes, NOS and angioimmunoblastic T-cell lymphoma, there's only anywhere from 25 to 40 patients in each arm, which then it becomes difficult to discern the efficacy. So this is just shown in a little bit more detail. I've focused in on the forest plot by subtype, keeping in mind the study was not powered to look at subtype specific differences, but we have most confidence in ALCL and more uncertainty in the other subtypes, particularly angioimmunoblastic T-cell lymphoma. As a result, we've seen some differences in regulatory approval of CHEP-BV around the world. So the FDA is always first, and it was broad based on the intention to treat population. Health Canada, we had a somewhat more restricted indication of the 3 main subtypes. And in Europe, it was fully restricted down to systemic ALCL, given that they were the predominant subtype going into the study. What about the need for consolidative transplant? If you improve your upfront therapy, maybe you don't need the consolidative transplant. This is what I was secretly hoping, but unfortunately, we can't use this data to do that. So we looked at this and presented it at ASH a couple of years ago. So confining the analysis to patients who are in a CR at the end of treatment, just to remove some of the heterogeneity, and then just asking the question of what is the PFS in patients who had a transplant or not. And you can see that the patients who had a transplant seem to have some benefit from that. Although this is an unplanned analysis, we're going to need more information to see which patients do not need a transplant in the CHEP-BV era. So I'm just going to spend the last few minutes about some ongoing debates on trial design in treatment-naive peripheral T-cell lymphomas. And there's really two approaches out there. One is to continue with what we've been doing, which is adding a novel agent to CHOP. And the other is to abandon CHOP altogether and evaluate novel agent combinations instead. So one thing I think in PTCLs, we have to ask ourselves, are we moving towards sort of more personalized medicine? I think there are some examples that are emerging for that, and I consider angioimmunoblastic T-cell lymphoma and TFH PTCL as sort of the poster child for this, and we're seeing collective evidence that they are sensitive to particular drugs. The first evidence of this came from a longer follow-up of the original registration study for romidepsin. Although the response rate was similar in angioimmunoblastic T-cell lymphoma compared to the rest of the population, there are some patients that have meaningful and very durable remissions, and in this case over 3 years. And I've certainly seen this in my own clinical practice. I want to circle back to the CHOP-ROSE study, and I asked myself whether if we enriched this study for TFH PTCL, would the story have been different? So this study was initiated prior to the most recent update of the WHO, so we don't have information on TFH PTCL, but focusing on an angioimmunoblastic T-cell lymphoma, it is definitely on the right side of the hazard ratio. So I'm hoping that we see a more detailed analysis of this and that they're going back and pulling out the TFH PTCLs. But it just kind of begged the question of whether we should have disease enrichment for these studies. Beyond HDAC inhibitors, 5-AZA shows excellent activity in relapsed refractory angioimmunoblastic T-cell lymphoma. So this is a small study, but the overall response rate was 75%, with half the patients having a CR, and median PFS of 15 months, although again, unstable curve with small numbers. Our usual PFS, median PFS in PTCL is 3 to 4 months. So this is looking quite promising. So kind of rethinking approach one and thinking about enriching the population that will benefit from the drug. This sort of ended up happening with the CHOP-5-AZA study that was presented at ASH this year. So this was a phase 1 study with broad eligibility, but at the end of the day, about 80% of the patients actually had a TFH PTCL. There's a couple of reasons, I think, for that. One, echelon 2 would have been reported during the conduct of this study. And of course, patients with ALCL and probably other CD30 positive PTCLs would have been shifted to that. But then, of course, there's also bias in investigators knowing the efficacy of 5-AZA, so you want to be putting your patients on this study. With early follow-up, I think the results are promising. The 1-year PFS of 66.1%. They did also build in correlatives that I think is really important. And although the numbers are small, there was a hint here that the cases with a TET2 mutation had a more favorable PFS, and those with a DNMT3A had a more aggressive course. And this has also been seen in other studies. So what are some studies that are planned or ongoing using CHOP with a novel agent approach? Well, one just was activated in China, which I thought was quite interesting, where they're using NGS and identifying mutations and then slotting patients into different arms and then having a comparator of CHOP. And then in the Alliance group led by Dr. Maida Shah, there's a randomized phase 2 study about to start, comparing CHOP or CHOAP, so investigator's choice, versus those regimens with either duvelisib or 5-AZA. And this study has very rich correlatives built in, so we can understand who's going to benefit from these treatments. Shifting to the other approach, so not using CHOP at all, but combining novel agents. So I just want to discuss 5-AZA and romidepsin, because I think this is the first combination that we've seen explored in the frontline setting. So it was first tested in relapsed refractory PTCL, and this was published in Blood a couple of years ago. The regimen was evaluated across a range of lymphomas, but there seemed to be a selectivity in T-cell lymphomas, which wasn't a huge surprise, given that we already know the single agent activity in both of these. There was a small expansion cohort in PTCL of 5 patients at the recommended phase 2 dose. More recently, we've seen results from the phase 2 study. It included both treatment naive and relapse refractory PTCLs. In the relapsed group, those 5 patients were pulled forward and also reported again in this study. But I want to focus on the treatment naive group. So there were 11 patients in total. 10 were evaluable. They did have 2 patients that weren't part of the response analysis. One had a rectal bleed from rectal cancer, and one actually had fatal sepsis. From the remaining 10 patients, their overall response rate was 70% and 50% had CR. So I think that compares quite competitively with CHOP. But I would also say that the novel agents are not toxicity free. So shown here is the grade 3 to grade 4 toxicity, and febrile neutropenia rate of 12% is probably similar to CHOP and higher rates of thrombocytopenia. So we do have to keep that in mind. This is the overall survival curve, and some of these patients would have gone on to transplant. And we have very short follow-up. So I think we don't know really at the end of the day whether these novel agents are curative, but I think this will be data that we'll be following closely. There are a couple of studies out there looking at combination novel therapies. One is already ongoing at Northwestern, evaluating romidepsin and lenalidomide, but taking the approach to focus on the patients that are not eligible for combination chemotherapy or curative approach. And another one that I found that's planned, combining AZA, romidepsin, and duvelisib, which is appropriately named HARD. So this is my final slide, just to leave you with some a few of the outstanding questions that I can think of for the primary treatment PTCLs. For ALK negative patients, I think we'll, we don't want to overtreat if somebody has a good prognosis, especially if we have CHEP-BV. But it would be, I think we need more information to know how to select those patients out. Probably most of the patients with DUS22 rearrangement, and there might be some with low IPI. I think it's interesting that the data would show up with ALK positive ALCL. How does that compare with CHEP-BV? Having said that, if I had the two side by side, I'd pick CHEP-BV given that it's excellent single agent activity. I think it'll be interesting for us to collect our real world outcomes and see these poorer risk patients and how they do with CHEP-BV. And I'm also interested in the impact on CNS relapse, recognizing that BV does not penetrate the CNS well. And that can happen in ALCL. In the non-ALCL group, I think there, we don't know as well the efficacy in those in CD30 positive PTCLs. They're underrepresented. We don't know the best cutoff. There is a study that's ongoing looking at patients with less than 10% CD30 positivity with CHEP-BV, so I think that'll be interesting. And then there's other PTCLs that can be very strongly positive CD30 like EDL, and that would be an appealing regimen to study. Clearly, CD30 negative is an unmet need, and the question is what trial direction. I think they both have merit, although I would favor the novel agent combinations if somebody wasn't a candidate for curative intent chemo. And moving forward, and what's already happening now, we're seeing smart studies being designed with very rich correlatives, and we are seeing some subtype specific studies as well. I didn't have time to show them, but there are specific studies in TFH PTCL looking at AZA, for example. And I'll just leave you with the upcoming PTCL talks over the next month that are a don't miss. Thank you.
Yeah, so thank you very much. Thank you very much, Kerry, and thank you very much, Laurence, for this really huge presentation and very interesting, and they really all work together. Do they have any questions? So there was a question from sorry.
Santi Mercadal.
Yeah.
Yeah. So actually, and if it is available in the centre, do you recommend NGS in all cases of T-cell lymphoma? Perhaps that's one for you, Laurence.
Yes, I guess that's a question for me. I must say I do it in almost all cases. Sometimes it is helpful for the diagnosis, especially for the TFH lymphoma with some phenotype which may not be fully expressed. If you find a mutation pattern that is that includes ROA or epigenetic markers, I think it adds to the definition. Although these criteria are not yet completely included in the recommendations for the diagnosis. We tend to do it. I cannot say it is mandatory for the first line diagnosis. I don't know, Kerry, how you do in British Columbia.
Yeah, we don't have access to NGS in routine clinical practice. Yeah, but I think there's a plan for a targeted panel in the future, but it would be just research setting, not in clinical practice.
Could I ask a question? Thank you both for such fantastic talks. Kerry, does the presence or absence of the DUS22 affect your auto decision?
Yeah, it's a good question. You know, we've just started doing DUS22 and P63 routinely, probably in the last 6 months. So most of the cases I haven't had that information on. I would use it, and I think, you know, it's complicated. We have some limited data saying that most cases, I think, do have a more favorable prognosis. But as you've already heard, that we had some in our own validation series that were treated with anthracycline-based chemotherapy and had an aggressive course. So I feel at this point you need to take all the pieces in together. But if I had a patient who didn't have aggressive features and a DUS22, yeah, I would use it, and I wouldn't routinely transplant that particular patient. But I wouldn't be overly reassured if I felt that a case was behaving very aggressively.
Okay.
I still have a transplant-related question with AITL, or the T follicular helper cell. We've started doing looking for clonal hematopoiesis in those patients going into autologous transplant, and often find CHIP or other abnormalities. And should we be using that to make a decision not to do an autologous transplant in those patients who, at least in our center, it seems like those folks with AITL or T follicular helper don't seem to benefit so much from transplant. They always seem to relapse or don't get there. But do you check for clonal hematopoiesis?
Is that Laurence? I think that's for you.
Well, we find clonal hematopoiesis in these, but TFH lymphomas, but I'm not sure what was the following of the question.
So if you found clonal hematopoiesis, would that impact on your decision to do an autologous transplant? Because you could increase the risk of subsequent development of MDS or.
This I cannot tell really. I'm not the one. I'm not the one deciding about the autologous transplant. I think in my center the decisions are really made on a case per case. They tend to do it in younger patients, but that's not systematic. And I cannot provide you an answer with respect to that clonal hematopoiesis.
I think it's interesting. The Nordic study, the results for angioimmunoblastic are actually quite good, like compared to the 20-30%. So I have a bit more confidence, but our problem has been getting them there, because I find that there's a lot that are refractory. And I'm actually really impressed with the allo data in angioimmunoblastic T-cell lymphoma. The other point is that because TFH-PTCL is so recently recognized, we actually don't have large-scale studies highlighting the clinical spectrum and clinical behavior. Just anecdotally, I've seen patients that they're just much more. They seem much more indolent. We're seeing limited stage. I wonder if it's just a spectrum and it's on the early spectrum. But I think it'll be really interesting to see some larger series, specifically of the outcome in TFH-PTCL, so we can figure out how to best treat those. Because I don't think it's exactly the same as angioimmunoblastic, except in the relapse setting, where they do seem to respond to the same, novel agents.
So there is a question from Shafinas. If ALK immunostain is negative, would you double check with a FISH probe, or is immunostain sufficient?
I guess that's a question for me also. We in principle rely on the ALK immunostain for identification of ALK positive. What I have seen a couple of times is the ALK immunostain being sometimes, of course, you need to have an external positive control to make sure that your reaction is valid. I have seen sometimes that staining could be maybe weak, and what I do sometimes is double check with the ALK clone we use for the lung cancers, because that assay is in our hands more sensitive, but in principle, ALK immunostain is very robust. So to the answer, no, we do not we do not double verify. Even with the some targeted assays looking at the fusions, because you may have new fusions not yet discovered, the immunostain, we've seen that in a study that a collaborator is doing in Rouen with a PCR-based assay, and actually the molecular assay missed a case that was positive by immuno because it was a new translocation.
And Kerry, I have a question for you. When we see how when we go deeply in the heterogeneity of PTCL, and when we see how it's difficult for pharma to go in such niche, do you imagine that if we want to jump the PFS of 35% to something which is really significant for PTCL, do you think that it has to focus to change the mind of PTCL, or we do have to imagine trial for each sub-entities, and that means that there are a lot of correlative work to do, which is not so easy. So how can you imagine the future of clinical trials and real the way to proceed to deal with PTCL? Because as we see, it's really difficult to include all the entities in the same population.
Sorry, you're asking about how do we move forward with?
Yeah, do you imagine that we move forward all the PTCL with all the heterogeneity of these entities all together, or do we have to deal with each entity?
Yeah. Lumper or splitter. I know. I'm a splitter, and when I started working on PTCLs, I remember that was the time when ALK negative ALCL was felt to be the same as PTCL NOS. We just keep getting more and more sophisticated, and I think we can treat the patients better if we split and understand the biology. But our challenge, of course, is disease rarity and how to do these trials. But I think there are some examples where that has been successful, and I alluded to the fact that there are specific studies in angioimmunoblastic T-cell lymphoma, TFH PTCL, looking at 5aZA, for example. There's a randomized study against investigator's choice. I think the LYSA group is doing that. But I think the second choice is, because we don't fully understand and we don't want to miss any patients that may benefit, is building in those correlatives so you can go back and understand. So I will also say, I think it's probably a little beyond the TFH and angioimmunoblastic T-cell lymphoma, and there might be some mutations that, if present, might also guide you towards certain therapies. And I've seen that in a couple of studies as well. And maybe Laurence can speak to this. The definition for TFH was, in my mind, slightly arbitrary. They picked two TFH markers. What about the cases that have one? What about one marker? Or maybe they have one marker, but they have a typical mutation profile. Maybe we'll be able to integrate that, and that might actually provide you with information on how to treat people. So I think, I know it's a bit of a long-winded answer, but I think we do have some studies that are specific, and the ones that are ongoing are throwing in those correlatives so we can build on it and then further define who's going to benefit from which treatment.
I think just to add on what you said, Kerry, you're totally right. So these two markers is a bit arbitrary. It is said 2, but better 3. Also, it is not mentioned. Some are like stronger than others. If you have CD10, CXCL13, I think it is stronger than having faint PD1 and ICOS, which are widely expressed in various kinds of exhausted or helper cells, even in normal lymph nodes. One definitively is not enough. The other point is, if you have a clearly cytotoxic lymphoma, for example, and it may happen that they are PD1 and ICOS, for example, also positive, then I think the cytotoxicity trumps the TFH, but there's a lot of not uncertainty, but lack of, concrete guidelines in these instances. And I think we are all learning. So we may know there's an ongoing still yet revision of the classification. And I think that's one of the points to revise or to refine, and also to integrate. Personally, if I find, this is what I said, if I find like a typical mutation pattern in one of those where the immuno is not so strong, I would tend to use that as an additional criteria, but a lot of it is a bit arbitrary, and it is not fully satisfactory to us to use that definition.
There was one question here asking, are there any indolent PTCL TFH subtypes that would we follow and not treat? So that was from Salvia Jane. I think that's interesting. I would say, for the most part, I'm not brave enough to do that, because I don't know how to select those patients out. But I will tell you one example where I have done that, but not necessarily in TFH. There was some reports of PTCL involving the thyroid in Hashimoto's thyroiditis. And so I had a patient very similarly who had a goiter and had a thyroidectomy, and it showed it was what was called PTCL NOS. It was CD4 positive. Also had papillary carcinoma, but we'll put that aside. And he had bone marrow involvement and circulating cells. So it sounds bad. Stage 4A PTCL NOS, bone marrow blood, but he was completely well, and it just seemed like over treatment to give chemo. I did a search of literature and I came across a series of 6 cases with exactly the same thing going on. And so I actually decided to not give him chemo, and now we're 6 years out. So I think within that garbage bag of NOS, we do have some indolent behaving PTCLs, and it would be very interesting to study that a bit further, because I think there are some that just don't benefit from chemo, and there's already been examples of that indolent GI PTCL that's called a lymphoproliferative disorder. There's one other question here that I'll just go to. I think we're probably getting close to wrapping up, but from Anne Dodera, said ELK negative ALCL with DUS22 rearranged have a good prognosis, and the few poor prognosis have different immunohistochemical characteristics. So I'm curious, I actually haven't seen that. We weren't able to, we're actually investigating this now, actually, trying to understand why our cases did poorly. But Laurence, are you aware of any immunohistochemical data of poor prognosis DUS22 rearranged cases?
No, I'm not aware at all. I'm aware DUS22 rearranged in general tend to have a different profile from those non-rearranged, like the lack of cytotoxicity. And
yeah, no, but within the DUS22.
Within the DUS22, I don't know. What I also don't know is if there is a relationship with that musculin mutation, for example, that's present in a subset of the case. I'm not aware of a biomarker that would stratify the good and not good responders, or poor versus good outcome, DUS22.
Okay, so thank you to everyone. It's really time to close the meeting. First, I really want to thank you, Laurence and Kerry, for this huge topic, and thank you for all yes, congratulations, and thank you for all the questions. You have been recorded, so you could go to the Women in Lymphoma site and just spread the news and say to your colleague. Secondly, I would like to thank Olivier Tournillac, our male colleague who is supporting the Women in Lymphoma. So welcome, Olivier.
Yeah, thank you. I was really quiet.
Bienvenue. Pas nécessaire.
I want to
chat anytime.
Thank MSD and Roche. Thank MSD and Roche for their support. And do not forget to register for the next week, which would be an Asia session. Please go to the site and register. It's very good quality and very important to spread this Wednesday, WiLing Wednesday. So thank you to everyone. Have a good day, have a good night, and see you next week.
Thank you.
Bye-bye. Thank you.
See you next week. Thanks all.